of cardiovascular disorders. We start with the exercise test. The exercise test is essentially used for the diagnosis, risk stratification, and the prognosis of patients with coronary artery disease. This is the commonest utilization of the test, but is sometimes used as well in other non-coronary artery disease, as we are going to detail in this lecture. So if you read the guidelines, you will find that there is extreme concentration on the contraindication for the exercise test because the indications are very obvious. The contraindications are divided into absolute and relative, and the absolute contraindication are essentially unstable coronary syndromes presenting with myocardial infarction or high-risk unstable angina. Of course, 48 hours after stabilization of unstable angina, you can exercise the patient if you are thinking of ischemia-driven strategy for treatment. Severe arrhythmias, whether it's a tachyarrhythmia or bradyarrhythmia, severe symptomatic aortic stenosis. Of course, nobody is allowed to exercise patients with aortic stenosis and the symptoms attributed to the aortic stenosis. But in patients with moderately severe aortic stenosis and asymptomatic as well, then an exercise test can be used to find out whether the patient is truly asymptomatic or symptomatizing, as well as the behavior of the gradient in response to exercise, as well as the blood pressure. Myopericarditis is obviously an absolute contraindication, and I call your attention to two important things that are frequently overlooked when you exercise the patient: aortic dissection and pulmonary embolism. They are absolute contraindication. Hypertrophic cardiomyopathy was classically classified as a relative contraindication, but we know now that it's a class 2A recommendation for exercise test in order to find out the effect of exercise on symptom production, as well as the effect on the gradient and whether ischemia develops or not. It's used as well to monitor the response to medical treatment if the patient is a candidate for medical treatment. Moderately stenotic valve disease, essentially aortic stenosis that's asymptomatic. Electrolyte abnormalities is a relative contraindication, and the blood pressure 200 over 110. So if you get a patient with 150 over 90, you can still exercise them. The contraindication is high up, 210, 200 over 110. And you can exercise a patient and you stop when the blood pressure reaches 250 over 150. Very high blood pressure, but that's the guideline. Now, this is the first question. 40-year-old patient with 2 months history of typical angina, and this is his the basal electrocardiogram. Have a look on the basal electrocardiogram, and then he was exercised, and he reaches the second stage of Bruce protocol, completed it, no chest pain. Blood pressure went up 20 points, and the question is what to do. Look at the ECG and try to answer this question. الو
المايك عند حضرتك كان مقفول كده، سامعين حضرتك؟
انا ما اعرفش ايه اللي قفل الحقيقه. طيب stop exercise because the heart rate reached 85% of maximum predicted heart rate, or stop exercise due to ECG findings, or stop exercise and order pharmacological imaging, or continue exercise until chest pain or ST segment depression becomes more marked. So if you look to this electrocardiogram, you will find that in lead V1, V2, and V3, there is an ST elevation. So ST elevation of 1 millimeter is an indication to stop the exercise test. So in addition, I will show you the previous electrocardiogram as well. You'll find pseudo-normalization of the T wave in the right precordial leads. but the ST elevation is very important to find. It has a localizing value. ST depression has no localizing value, as you know, although some pioneers still insist that it has a localizing value, but the guidelines is unanimous on this point. There is no localization by ST depression, but ST elevation of minor degree localizes the point of ischemia and usually denotes a severe stenotic vessel in that territory and is an indication to stop the test immediately. Otherwise, you will find this. You will find ventricular tachycardia. So, and this patient, because the ST elevation occurred in the right precordial leads, you have a critical stenosis in the proximal LAD. Another important point, if you look to the location where the ST elevation is occurring, you will find that there is a Q wave. But if you go back to the the original electrocardiogram, there is a small R wave in V2 and V3. So you cannot depend on elevation of the ST segment in patients who are carrying a Q wave in that electrode, in that area. The Q waves appeared later on, probably because of changing in the cardiac axis as a result of increased respiratory rate. But you can, if the patient is having a Q waves in the right precordial leads, then this is a reciprocal movement because of the presence of a scar in that territory. So the important point is that if you get ST elevation in leads that's not carrying a QS or a QR complex, that's very significant indication of the severe ischemia, severe stenosis in the supplying vessel, as well as an indication, strong absolute indication for termination of the exercise test. Now, what are the other indications for termination of the exercise test? Absolute indications, according to the guidelines, patient desire because of symptoms, angina of moderate or severe degree, drop of the blood pressure below the baseline. It's important to know that the guideline is emphasizing that the blood pressure drops 10 millimeters of mercury or more below the baseline, not below the preceding stage. CNS symptoms like ataxia or dysarthria or fainting, ST elevation more than equal or more than 1 millimeter, as we indicated just now, sustained ventricular tachycardia, or if you have a technical difficulty in fixing the electrodes, or other poor signs of perfusion like fainting, severe fatigue, and so on. A relative indication for termination of the test includes increasing chest pain, even if you feel it's non-anginal, drop of the blood pressure of 10 millimeters of mercury, and even in comparison with the preceding stage. And look at this, the blood pressure of more than 250 over 150. It's very rare to find that the diastolic blood pressure rises. Usually the systolic blood pressure rises, the diastolic blood pressure increases a little bit or stays almost the same. ST depression more equal or more than 2 millimeters also is an indication for termination of the test, because otherwise you are looking for what in addition to that. This is a positive test. Complex arrhythmias, and if you find that there is white QRS complex and you think it's because of right bundle branch block aberration, and you cannot distinguish the white QRS tachycardia, whether it's due to right bundle branch block aberration or ventricular tachycardia, under these circumstances you ought to terminate the test. Now, this is the sine qua non, as everybody knows, the sine qua non of a positive test. Usually when you exercise a patient and he is going to turn out to be positive, the initial stage is depression of the J point. And if you move 1.5 to 2 squares, that's 0.06, 0.08 milliseconds, then you will find even at the terminal point of 0.06, 0.08, it's still 1 millimeter below the baseline. It's important to know that the changes should be in 3 consecutive cardiac cycles, not only 1. And then the way you identify the baseline is to look at the top of the R waves, not the baseline which is in the TP interval, because this is going to confuse you. The top of the R waves in 3 consecutive cycles should be isoelectric, should be at the same level, and at the same time you look for the point which is separated from the J point. The J point is the junction between the descending limb of the QRS complex and the ST segment. You look to the point which is away by 60 to 80 milliseconds, and find out how far it is from below the baseline. If the patient continues to exercise, then the ST segment changes into an isoelectric flat depression, and then if he continues to exercise, usually you get a down slope. And sometimes you don't get them in that order. So if you get any of these changes, that's an evidence of ischemia, particularly the middle one and the one to the right. If you include the one to the left, you increase the sensitivity of the test, but you decrease its specificity. And I will detail that in the next slides. Here we go. These definitions are extremely important. The sensitivity is the true positive divided by the true positives over the false negative. So I wanted to call your attention to the fact that if you decrease the false negative, you increase the specificity, the sensitivity. In other words, a very sensitive test has no false negative result. So a very sensitive test, if you get a positive result, it's true positive, because the false negative is zero. So as you increase the sensitivity, you decrease the false negative result. Specificity is the true negative divided by the true negative plus the false positive. In other words, if you increase the specificity, you decrease the false positive results. So if you have 100% specificity of any test, then the false positive results will be zero, because the true negative over true negative will be 1 or 100%. The predictive value is the true positive divided by all the positive results. The predictive negative value is the true negative over all the negative results, and accuracy means the true results divided by all tests. And I will come to this again, but this is extremely important. So remember that as you increase the sensitivity, you decrease the false negative result. So if you get a negative result with a sensitive test, it's true negative, no doubt about it, because there is no false negative. Specificity, as you increase specificity, then you decrease the false positive result. So if you get a positive result with a highly specific test, it's true positive, and there is no way that it becomes a false positive. This is very important, because these are characteristics of the test, but they tell you how to use them and what is the significance. If you are thinking of, for example, a tumor marker, and the tumor marker has a high specificity, and it turns out to be positive, then the specificity is high, so this positive result must be a true positive, because if you have a high specificity, the false positive result is going to be very low and approaching zero. Now, this leads us to the important theory, the Bayes theory. The Bayes theory is a probability, because the test doesn't tell you whether the patient is having ischemia or not. It just shifts the probability between low probability of ischemia or high probability of ischemia. The test is far from being accurate, as I will show you, but it has a special utilization, but it's important to understand the theory behind its utilization. So if you look into the line of identity between the pre-test probability and the post-test probability, in this area, which is an intermediate pre-test probability, which is defined in this particular test between 10% and 90%. This is not the definition in other situations, but in this particular test, it's defined between 10 and 90%. If this is the line of identity and the patient gets a negative result, then he moves away from it. Let us say he had a pre-test probability of 40%. If the result is negative, it's going to go down from 40% to 20% or less. If he gets a positive result, he changes from 40% to 60% or more. As you increase the specificity of the test, the true positive approaches 100%, because as I showed you from the formula before, the false positive is going to be diminishing towards zero. So if you get a positive result in a highly specific test, this means that the positive result is true positive. The possibility of being false positive is dwindling towards zero. On the other hand, if you increase the sensitivity of the test, then with increasing the sensitivity, you decrease the false negative. So if you get a negative result, it's a true negative result. So a highly sensitive test, a highly sensitive test with a negative result ensures you that the result is negative. So that's the way we use the test. And this is the importance of the Bayes theorem in understanding how to utilize a test which is short of being highly perfect. And this is the meta-analysis which was published several years ago. The test has a sensitivity of 68. This is the exercise ECG test, 68%, and a specificity of 77%, and the accuracy of 73%. Is that acceptable? Obviously, it's not acceptable, because this means that you are going to miss about 1/3 of cases with ischemia. You are going to miss their diagnosis. Is that accurate? Again, it's not accurate. Why it's not accurate? Because of what's called the verification bias. What is that? This can be explained by this diagram. If you start with 1,000 patients, you exercise them on the treadmill Bruce protocol or any other protocol, Norton's protocol or AMP protocol or whatever, and then 3/4 of them are negative and 1/4 of them is positive. The negative, of course, you'll say, okay, your test is good, go home. Very rare, some few patients of them, they get recurrent chest pain, so you take them to the cardiac cath, but the number of cardiac cath among this negative population is going to be very small. On the other hand, those with the positive test, not all of them will go to the cath lab. Let us say half of them will go to the cath lab. So it ends up that you cath the patients which are dominated essentially by the positive test. So as a result of that, the sensitivity gets high, because here the positive tests are here in the upper part of the equation. So if you look to that, if you are going, this is the way, this is the final arbiter by which you are identify positive and negative tests. If you look to patients who are going to the cath lab, the majority of them having a positive test, the minority are having a negative test. So as a result of that, the cath lab will tell you that the true positives are high and the sensitivity will be inflated. On the other hand, the negative results will be very small, including the true negative and the false negative. So as a result of that, you will get a downgrading of the specificity. So the verification bias tells you that the test, without correcting them for this form of bias, is having a higher sensitivity than what's real and a lower specificity than what is real. So this is the So this is the correction. Sensitivity and specificity. Has anyone did that? Yeah, in 1998, and as a result of that, we found that the sensitivity is not actually 68, it's 45. And the specificity is 84. So as I told you, the verification bias is actually inflating the sensitivity. This is the true sensitivity. This is the inflated sensitivity as a result of the verification bias, and is slightly higher than those not corrected for the verification bias. So this applies not only to the exercise ECG test, it applies as well to exercise activity. And the exercise is ECG test, you will find if you correct it for the verification bias, it's decreased. The non-corrected sensitivity. Same applies to exercise nucleus. It gets increased if you correct for verification bias, both for the exercise treadmill test as well as for the exercise echo and the exercise nucleus. So this is very important to understand that we are not dealing with perfect tests, and you cannot. There is also a confounding factor, which is the verification bias. Can we correct the verification bias without catheterizing the patients? Yes, but this requires high mathematics, and the result is not a correction for verification bias, but it's called the normalcy ratio. So the normalcy ratio, if you read it in the guidelines, means the sensitivity and or the specificity corrected for the verification bias. So I hope that's clear. But if this is not clear, we can discuss it again in the. Now, what about the diagnosis of coronary artery disease using this imperfect test? Don't depend on computer analysis to analyze the ST segment, because if you depend on that, the computer cannot recognize wandering baseline. If the baseline is perfect throughout the tracing, which is rarely encountered actually, then you can depend on the computer diagnosis. If the patient has a right bundle branch block, the ECG is still interpretable, but you have to look to the lateral leads, not the inferior leads, and not the leads which shows the right bundle branch block pattern. If there is left bundle branch block or a pacing or a type B WBW, then under these circumstances, the ECG is interpretable, and you have to go to exercise imaging. Factors that decrease the sensitivity include beta blocker and poor exercise capacity, and factors which reduce the specificity is resting ST changes, whether digitalis or left ventricular hypertrophy and strain. Left ventricular hypertrophy by itself without strain does not change your opinion from shifting from an exercise ECG to an exercise imaging. ST elevation localizes the ischemia but not ST depression, and both sensitivity and specificity are less accurate and definitely lower in women. So to women, let's answer this question. Which statement concerning stress test in women is accurate? A, standard exercise treadmill test is recommended as the initial test modality in low intermediate probability of coronary artery disease. B, exercise imaging is recommended as the initial test modality due to high incidence of false positive results with positive ECG, exercise ECG. C, pharmacological imaging is recommended as the initial testing modality due to poor exercise capacity. And D, the standard exercise treadmill test is as accurate for diagnostic reasons in women as in men. The correct answer is A. The A is a standard exercise treadmill test is recommended despite being less specific and less sensitive. Still, it is the recommended test for exercise as an exercise test for women. There is no indication according to all the guidelines of shifting the exercise from just an exercise ECG to an exercise imaging because of changes in gender. And this amplifies that. If you look into the meta-analysis on the left side of the screen, you will find that the difference between sensitivity and specificity between men in blue and women in pink is just very small amount. There is no P value, unfortunately, for this analysis, but at least qualitatively, the difference between men and women for both sensitivity and specificity is minimal. And if you look for the value of the exercise ECG test against the value of the exercise imaging for risk stratification, again, in women, there is no difference. So whether the patient is having a normal exercise capacity and normal exercise response or an abnormal response, the difference between men and women is just statistically insignificant. The only the difference is in the price, is in the cost of the test. It's being double in patients undergoing exercise imaging. So we do for women if the exercise ECG is if the ECG is interpretable, still the exercise treadmill ECG is a test of choice. Now we move from the diagnostic value of the test to the risk stratification. It depends on what kind of population you are going to risk stratify. If we are dealing with a general population, you don't need an exercise test. We don't do an exercise test for asymptomatic general individual among the general population. You do the pooled cohort equation, and as you remember from this lecture on the use of statin and cholesterol, they are divided into a low, intermediate, and high risk groups. And the low, intermediate, and high risk groups is 5% in 10 years mortality. If you divide the 5% by 10 years, then it's going to be an annual mortality, annual occurrence of myocardial infarction and stroke as well is 0.5%, intermediate between 0.5 and 0.75, and elevated more than 0.75. This was the 7.5 which we mentioned before in 10 years. And depending on that, the recommendation is to do for the low risk category a lifestyle modification, for the high risk category statin. And if you can remember, we said that for the intermediate risk category, we have to go to risk enhancers using a calcium score and so forth. On the other hand, if you are going to risk stratify patients with stable angina, of course, most of the patients of unstable angina or myocardial infarction or acute coronary syndrome, they are going to hide except in a special way whether to send them, which is the majority of the cath lab or not. But patients with a stable angina, they have to be risk stratified into a low risk category. Now here the end point is mortality alone, and they can be classified in a different way: a low risk category, intermediate risk category, and high risk category. And the best way to do that is to use the Duke score index, which I'm going to detail just now. And the low risk category is having an annual mortality. This is the end point I said is death. Annual mortality less than 1%, the high more than 3%, and the intermediate in between. And depending on that, you can choose medical treatment for the low risk category, and you can send patients to the cath in the high risk category and individualize the therapy in patients with intermediate risk category. Now, is the test equally effective like the cardiac cath? No, cardiac cath is still the best method by which you can prognosticate and risk stratify the patients. This is an old study which showed that the mortality rate, annual mortality rate, is much higher in patients with left main coronary artery disease, approaching 8% per year, as same as for 3 vessel disease, and is intermediate for 2 vessel disease and 1 vessel disease. But if you put our figures on the horizontal line, this is the 3% mortality which we should just mention. This is the 1% mortality, but it seems as well that you can get a good idea if you have an exercise test that can be categorized as high risk, then it's going to choose the 2-3 vessel disease and left main disease. So it's not perfect, but it gives a reasonable idea about the risk without moving to the cardiac catheterization ahead of time. Now this is amplified by a study from the Duke registry, which is a huge registry, and it shows you that if the patient exercises on a regular Bruce protocol and reaches stage 1 only, completes stage 1 only, and is positive, the result is positive, the incidence of coronary artery disease is 98%, out of which 73 are having 3 vessel disease and more than 25 are having left main coronary artery disease. On the other hand, if the patient reaches the 4th stage of Bruce protocol and the test is negative, he still can have coronary artery disease. 1/3 of them are having coronary artery disease. But look at that, the incidence of coronary or 3 vessel disease is 9% and only 1% possibility of left main. So as I told you, the test is a test of shifting probabilities. It's not an absolute test for detecting ischemia. And by the way, we will now mention that ischemia should not be the final arbiter, although it's the index which moves us towards cardiac catheterization. But we will detail that very soon. Now, is there any other variables that should be gleaned from the exercise stress test? Of course, duration is the most important variable in detecting the outcome of these patients. If the patient cannot exercise at all, that's by itself a poor prognostic sign. Exercise hypotension, in the way we just explained at the beginning of the lecture. Chronotropic incompetence, we have variable definitions of chronotropic incompetence, but the most accurate is the ratio between the maximum achieved minus the resting dividing by the maximum predicted minus achieved. So maximum achieved minus resting divided by the maximum predicted minus resting. If it's less than 0.8, this is an indication of chronotropic incompetence. Impaired heart rate recovery, there should be a recovery or a decrease of more than 12 beats per minute in the first minute post-recovery and 22 beats per minute in the second minute post-recovery. And the impaired heart rate recovery is an important prognostic value. And then the ST segmented changes. So as you see, the ST segmented changes is ranking here behind 4 other factors, including the magnitude of the depression and whether there is ST elevation in lead VR or not. And then the occurrence of angina. And of course, we doubt the value of ventricular ectopy, particularly in risk stratification, particularly in patients with good ventricular function. Now, this is the Duke treadmill score, which I think should be included in every report about the exercise stress test. First of all, it's applicable only to patients below the age of 75, has not been tested in patients above that age. The second important point, it should not be done by any exercise modality except the regular Bruce protocol. Most of the cath lab in this country are using modified Bruce protocol. You cannot calculate the Duke treadmill score from the modified Bruce protocol. It should be a regular Bruce protocol. Why is that? Because the duration is the most important part of the score. So what's the score? It's the duration in minutes minus 5 times the degree of ST deviation in millimeter, whether elevation or depression, minus 4 multiplied by the angina index. So what's the angina index? Is 0 if there is no angina, is 1 if there is no limiting angina. He got angina, but he was not, he doesn't want to stop. And then 2 if it's limiting angina, which forces the patient to stop. Now, this is an important index, easy to calculate, provided that you have the precautions that I just mentioned, age below 75 and a regular Bruce protocol of exercise. It tells you a lot of things. Number one, it tells you whether the patient is having a low risk, the low risk category, intermediate or high. The low risk category, the score is equal or above 5. The intermediate between minus 10 to plus 4, and the high is less than minus 10. And it tells you the mortality in an almost accurate way. So in the low risk categories, you have a mortality of 2.5 per 1,000. You cannot get more assurance for the patient except by such very low figures. And you get a mortality of 1.3% for patients with intermediate risk score, and you get a high mortality rate of 5% in patients with high Duke treadmill score. So it's a very variable score and can divide your patients into low, intermediate, and high risk categories. And by this, you can think and procrastinate about the number of visits involved, as I showed you in a previous slide. Now, what's the association between ischemia and outcome? We have been driven for a long time by ischemia. The patient gets ischemia, then he goes to the cath lab and gets intervention. And we are doing that until now. But we know that from the large studies that have been published over the last decade, that there is a dichotomy between the occurrence of ischemia and mortality or the outcome in general. So this has been supported by the findings in the cardiology trial. There was no statistically significant connection between the occurrence of ischemia and mortality or any form of outcome. And as well as in the Barry trial and in the Stitch trial, there is no statistically significant association between them. And then remember the ischemia trial at the time of making this study, this slide, the ischemia results was not published, but you remember from the ischemia trial, this is a large number of patients, 5,000, and it turned out that the occurrence of ischemia doesn't tell you anything about the prognosis. And therefore, in patients with a stable angina, you have to go by the symptomatic condition. You cannot send the patient because he's having evidence of silent ischemia only by the presence of resistant symptoms which are not responding to optimum medical treatment. So depending on all these large randomized trials, including the recently published ischemia trial, we are now getting away from what we had learned before from observational study. So probably ischemia is not going hand in hand with the outcome because there are other variables like ventricular function, like comorbidities, like the susceptibilities to arrhythmia, and so forth. So until now, we don't know what to do exactly, but we have to know that in patients with a stable coronary artery disease, the occurrence of ischemia should be linked to the whole situation of the patient and deciding which is the optimum line of treatment for these patients. Not only ischemia, because this is very important to know that ischemia, which is driving our behavior so far, is not linked to outcome by all recent major trials. The illusion which we had before was because of many observational trials linking both, which turned out to be not exactly the case. Now, if we move away from coronary artery disease, the exercise test can be utilized in other conditions. In hypertrophic cardiomyopathy, there are a couple of 2A to estimate the functional capacity and response to treatment and to prognose patients with drop of the blood pressure 20 points below the baseline. In patients with asymptomatic aortic stenosis, as we said, there is no point in exercising symptomatic aortic stenosis, absolutely contraindicated. 2A for patients with asymptomatic severe, in order to find out whether the patient is really asymptomatic, prognosticate about the future of the patient. And we are looking essentially not for ischemia, but for drop of the blood pressure. And in patients with congenital aortic stenosis who are having a gradient more than 30 millimeters of mercury and planning to participate in sports. In patients with arrhythmia, we have two class A indications and some class 2A indications. And of course, in a rate adaptive pacemaker response, you wanted to know whether the response is acceptable to the patient or not. In patients with congenital complete heart block, planning to participate in sports, in exercise-induced arrhythmia for the sake of the diagnosis, and also for the response to treatment. In patients with atrial fibrillation, when you are looking for ischemia, this raises your suspicion, and if you are looking for the adequacy of control of rate control. The cardiopulmonary exercise test, there are two accepted indications. The cardiopulmonary exercise test, we are going to prognosticate for congestive heart failure if transplantation is in vogue. The most important two cardiopulmonary tests is maximum oxygen consumption and the anaerobic threshold. Both of them are decreased. Or if you are dealing with unexplained dyspnea that you don't find out despite initial investigation whether the patient is having a thoracic pulmonary disease or a cardiac disease, under these circumstances, the best test is a breathing reserve. The breathing reserve is 1 minus minute ventilation divided by maximum voluntary ventilation. So it's the difference between both. The formula is 1 minus minute ventilation divided by maximum voluntary ventilation. This is decreased in patients with pulmonary origin of dyspnea and is not affected in patients with cardiogenic disease. So next question is, a 55-year-old man is having exertional back pain. The resting ECG is on the left, the exercise ECG on the right. Have a good look on the both ECGs, and then I will give you the question. Now the question is, and I will go back to show you the ECG again. Interpretation of the exercise ECG. What is the true answer among these four choices? A, severe ST segment depression in multiple leads is suggestive of left main or three-vessel coronary artery disease. B, ST segment elevation in lead AVR is suggestive of right coronary spasm. C, ST segment depression non-diagnostic of ischemia due to abnormal resting ECG. D, ST segment depression likely false positive due LVH on the resting ECG. Now the answer is actually C. Why is that? ST segment depression is non-diagnostic of ischemia due to the abnormal ECG. Let's go back to the ECG. If you look to this ECG, actually this is a WBW. There is a slurring here of the initial QRS complex. There is a positive complex in AVR, and there is a QS complex in AVL. This combination, this is a right bundle branch block, so it must be an accessory pathway in the left ventricle, and it's positive in the inferior leads, so in 2, 3, and AVF, so it must be an anterior, and it's moving from the lateral towards the right, from the left towards the right side, because it produces a QS complex in AVL. So it's a left ventricular anterolateral accessory pathway.
محمد هو الصوت بيقطع.
والله طب خلينا اشوف تاني. هو النهارده مش لا مفتوح عندي. كده معقول؟
كده سامعين حضرتك.
كده معقول. طيب. So this is انا من اول الاي سي جي مسموع ولا اقوله تاني؟
لا لو ممكن حضرتك تقوله تاني. ممكن حضرتك تقوله تاني يا فندم.
Okay. Now this is a tricky ECG because if you look into the exercise ECG result, there is a significant ST depression in the lateral leads here. But actually this ECG is you cannot interpret it. Why you cannot interpret it? Because the baseline ECG is a WBW. Remember, in certain forms of WBW, particularly in patients who are having an accessory pathway far away from the SA node. In this condition, the accessory pathway is on the anterior part of the ventricle. الصوت بيزيق.
يا جماعة اللي عنده أطفال يقفل الموبايل لو سمحت.
So if you look into this ECG, it's positive here in V1. So if it's positive in V1, we said that before, this means that it's left ventricular in origin. So because if it's left ventricle, the left ventricle is a posterior structure, so the activation is moving anteriorly, produces positive complex in V1. And at the same time, it's positive in the inferior leads. So as a result of that, it's located in the left ventricle and is anterior. So it moves posteriorly or inferiorly. And at the same time, it's negative in AVL. So it's moving from the lateral part of the left ventricle to the right side of the heart. So it's an anterolateral left ventricular accessory pathway. Being away from the AV node, because in the lateral part of the left ventricle, the impulse reaches the AV node easy. So it passes from the supraventricular to the ventricular compartments through the normal pathways, and a minor part of it goes to the accessory pathway. Remember that in certain conditions, for example, the right bundle branch block of Epstein's anomaly is associated with right accessory pathway, which nullify each other and produces an ECG like this. A very narrow QRS complex, very small delta wave, and you can easily miss the diagnosis. If you exercise this patient, you miss the game. You get a false impression that it is ischemia, whereas if this patient is having ischemia, a suspicion of ischemia, he should, of course, go to exercise imaging, not an exercise ECG. So that's the point that I wanted to make in this. So the correct answer is The correct answer is C, which says that ST segment depression non-diagnostic of ischemia due to abnormal resting ECG. And this is an amplification of the resting ECG, and it shows the delta wave, a minuscule delta wave that you should be attentive to it in order to miss the situation. Now, this is important. If you compare the sensitivity of the exercise ECG test with exercise imaging, which is present here in yellow line, there is no doubt that exercise imaging is more sensitive. It might be the same sensitivity, the specificity for all of them, but sensitivity is definitely for imaging is better. And in addition, the incremental value or the incremental diagnostic value of exercise imaging, whether we are talking about exercises nuclear or exercise echo, I will show you the exercise echo. Let me move this. And the exercise echo. You will find that, again, imaging is superior in having an incremental diagnostic value. So if it is more sensitive and having incremental value, why we don't do for every patient exercise imaging? Now, the answer of this is the coming 2 slides. Now, this was a study which was done several years ago, 400 patients having normal left ventricular function in order not to have a confounding effect of impaired left ventricular function, and having a normal baseline ECG, resting ECG, in order to have a high specificity for the diagnosis. And what was the result of exercising these patients? Actually, all of them have been exercised. As I said, 400 patients, so it's not a small number. And this is the ECG model, and this is the imaging model, SPECT nuclear model. And here in the green is showing the patients who have been classified by the ECG model and those classified by the nuclear model. Look at the difference, very small difference. So there is no incremental value actually of doing the nuclear, particularly in patients with a normal baseline ECG. And if you have a normal baseline ECG, that's enough to predict that the ejection fraction is normal. So in certain patients, still we have no choice except to submit them to a regular exercise ECG. Why is that? Because there is no difference in classifying these patients. If you classify patients who are doing the ECG only, you get a correct diagnosis in 55%, and then in imaging is just 58. Although the difference in price, this study was done in 1994. So this is money belonging to this era. And the difference was 20,000, even more than $20,000. So imagine there is no point in submitting these patients to more expensive tests. If you look to the unclassified, also there is minor differences. If you look to the incorrect classification, there is no difference at all. So if you have a subset of patients in which the electrocardiogram at baseline is normal, and this connotes at the same time as having a normal ejection fraction, there is no point in submitting these patients to imaging. So what's the bottom line in choosing the test? The bottom line is in choosing the test, and this is the last slide, is that look, if the patient is able to exercise, then you do an exercise test. You don't do a pharmacological test. If he's not able to exercise, it's pharmacological test. This by itself connotes a high risk, because as I told you, the duration of exercise is the most important variable that clarifies the prognosis of the patient. And then you look whether the ECG is interpretable or not. If it's interpretable, then you do an exercise ECG test. If not, you do an exercise imaging. But what's interpretable? The patient who is lacking the left bundle branch block based electrocardiogram, WBW, or equal or above more than 0.5 millimeter of ST depression. Any of these things moves you to exercise imaging. If the patient is having low to intermediate, exercise stress test, exercise ECG test. If he's having intermediate to high, then imaging, because you don't want to miss any of these patients because of their intermediate to high pretest probability. So I stop at this stage and I get the questions related to the subject. And next time we'll have a long lecture about exercise nuclear. Okay. I hope ان الصوت اتسمع في اغلب السلايدز. محمد
يا دكتور محمد انا وحضرتك هو لسه ما جاش اسئله.
طيب بس سمعك الكلام؟
تمام.
If there is no question then we stop.
في سؤال جه بيسال.
لا هو ابتدوا يا بيه معلش بعد اذن حضرتك، انا يعني هم ابتدوا يشتغلوا على الباندل برانش بلوك باترنز. احنا بنحب برضو لو حضرتك تقدر تسمرايز ايه الاي سي جي ابنورماليتيز اللي تمنعني من استعماله كتست فور كورونري ارتري ديزيز. في ناس بتسال على الباندل برانش والموداليتي اللي احسن منه.
اوكي.
I want to exercise. حضرتك قريت الاكزامبل بتاع الدبليو بي دبليو ده، الحقيقه انا ما كنتش عارفه الاجابه، انا يعني مشيت في سكه ما خدتش بالي من الدبليو بي دبليو.
ما عرفتيش الاجابه يبقى السؤال غلط.
طيب كتر خيرك.
الباندل برانش بلوك ليها حكايه. اذا كان في ليفت باندل، اذا كان في رايت باندل برانش بلوك، لوك تو في 5 في 4 في 5 في 6. في 4 في 5 في 6 includes 85% من الدياجنوستيك باور بتاع ال 12 واحيانا ال 15 ليد الكتروكارديوجرام. ايه هم ال 15 ليد الكتروكارديوجرام؟ هم ال 12 زائد الاكس واي زد اللي هي الاورثوجونال ليدز. وبالتالي رايت باندل برانش بلوك از نوت ا ديل. الديل هو الليفت باندل برانش بلوك. الليفت باندل برانش بلوك you get abnormal activation of the left ventricle. Remember the electrocardiogram is an electrical image of the left ventricle. ما هوش of the right ventricle. left ventricle is dominated. فلما تحطيه في موضع انت كل الليفت ventricular conduction فيه abnormal, obviously you cannot read الchanges اللي بتحصل. نمرة 2 ان الليفت باندل is very frequently associated with significant repolarization abnormality. Logic. ليه؟ لانك انت activating muscle to muscle conduction in a big mass of the heart اللي هو left ventricle, so repolarization will be grossly abnormal. So this obviates انك تستخدمي ان exercise ECG test في الدياجنوزس بتاع الليفت باندل. ايه اللي بيشبه الليفت باندل؟ WBW. خصوصا ان الدبليو بي دبليو ده لو كان طالع من الرايت فنتركل رايت اتريوم تو رايت فنتركل it looks like a left bundle branch block. But generally WBW is a diagnosis في الاي سي جي WBW نقطه. ما تقدريش تشخصي مع الباندل WBW اي حاجه ثانيه. ده ليفت فنتريكولار هايبرتروفي ولا باندل برانش بلوك ولا اسكيميا ولا اي حاجه. WBW نقطه. كان الحاجات دي ممكن تبقى موجوده. بيس ده ريزم لان احنا بنبيس من الرايت فنتركل. وطبعا ده بقى منسحب على السي ار تي. اذا بيست ريزم نفس الحكايه. اذا عندنا حاجات فيها اس تي سيجمنت، الاس تي سيجمنت اللي انا مكتوبه دي يعني في الواقع تشمل عده حاجات، وهو left ventricular hypertrophy and strain. left ventricular hypertrophy بس is not a contraindication in using the exercise ECG test. لكن left ventricular hypertrophy and strain or ST segment depressed because of electrolyte changes or ST segment depression because of any other factor. كل الحاجات دي هي تخليني ابعد عن الاكسرسايز اي سي جي تيست واروح للاكسرسايز ايمج. في حاجه ثانيه، افرض ان العيان بتاعي انا مهم جدا ان انا مش عارف انه عنده اسكيميا ولوكالايز الاسكيميا. عيان عامل بي سي اي من 6 اشهر، خدي بالك من 6 اشهر لان في 6 اشهر الاولانيه ما بنعملش اكسرسايز تيست لان الستنت هاز نوت بين اندوثيليالايزد، او several years after doing coronary bypass وانا عاوز اشوف التريتوري بتاع الاسكيميا. So الاكسرسايز اي سي جي will not be helpful الا لو وراني اس تي elevation، واحنا ما بنحبش نشوف دي لان العيانين دول بيخشوا في اريزميا اون ذا تريدميل بتبقى اشكال. So exercise imaging should be done under these circumstances. نرجع للليفت باندل اللي اثرتها الدكتوره وفاء. ليفت باندل برانش بلوك باترن في الاكتيفيشن بتاع الفنتركل فيه اشكال، وهو انك انت ما تقدرش تعمل اكسرسايز ايمجنج برضه. امال تعمل ايه؟ تعمل فارماكولوجيكال ايمجنج، فازودايليتور ايمجنج. واي؟ because exercise imaging او دوبيوتامين imaging هيؤدي increased contractility في السبتم، وبالتالي بيبقى في حته هنا هو موريه ان في اسكيميا في السبتم. لما تعمل كورونري انجيو يطلع ولا في اسكيميا ولا اي حاجه، وبالتالي بقينا الليفت باندل برانش بلوك كونترا انديكيشن للاكسرسايز اي سي جي at the same time contra indication للاكسرسايز imaging and is an indication for vasodilator زي adenosine or regadenoson imaging. So this is the story of the left bundle branch block. فيش أسئلة تاني؟ واضح إن كنت النهارده من عبثين.
لما ابتدينا نشتغل سوري يا محمد معلش، لما ابتدينا نشتغل الاس جي في اسم 23 ايام دكتور يحيى سعد، كان في رساله او ريسيرش بيقول انا مش المفروض احط السته او احط التشست ليدز كلهم، وممكن اكتفي بفي 1 and في 5. ايه راي حضرتك في الموضوع ده؟
يعني الدكتور يحيى سعد سافر فرنسا وتعلم بعض الحاجات في الاكسرسايز تيست. من ساعه ما رجع احنا ما كناش متفقين معاه في عده حاجات في كده اهو. فكان مثلا ان هو بعد العيان ما يعمل اكسرسايز يخليه قاعد عشان ما ينامش على ظهره، علشان يبقى عنده اريزميا ولا ما عندوش اريزميا. فكان الاكسرسايز تيست اللي بيتعمل في فرنسا في الوقت ده هو اكسرسايز تيست ما هواش اللي متفق عليه في بلدان اخرى. بالعكس احنا كنا في امريكا في الوقت ده بنعمل زي ما قلت لك 15 ليدز، بنعمل اكسرسايز 12 ليدز العاديين زائد اكس واي زد. لكن في الواقع هو في بوينت ان فيفر باللي كان بيعمله الدكتور يحيى سعد، وهو ان ايه؟ في 85% من المعلومات في اللاترال ليدز، وهو في ليد في 4 ليد في 4 وفي 5 وفي 6، لكن انت هتمس 15. في الوقت ده احنا ما كناش عارفين ان الاكسرسايز تيست از امبيرفكت تيست. زي ما انت شفتي انك في كوركت الاكسرسايز تيست للفيريفيكيشن بايس انت عندك سنسيتيفيتي اقل من 50% 45%، فانت عاوزه تلمي كل الانفورميشن بكل الوسائل اللي عندك. فكمان لما كمان تقللي الليدز اللي انت بتكسبلور بيها الاسكيميا هتقللي الدايجنوستيك باور. كل الستاديز اللي معموله ببلش ان ذا ليترشر وبالتالي الجايد لاينز معموله على اتليست 12 ليد الكتروكارديوجرام. سو الكلام بتاع الدكتور يحيى سعد. في البدايه كانت الاجهزه كمان بعض الاجهزه ما فيهاش الاي سي جي بيرسم 12 ليدز مع بعض او بيرسم 6 ليدز مع بعض، كان بيبقى فيه
3 3
ما كانش فيه 3 كان واحد. فكان فور ذا سيك اوف بريفيتي وايزينس انك انت تحط في 4 وفي 5 وفي 6، لكن لا، هو 12 ليدز او 15 ليدز بعض الالكتروكارديوجرام ممكن تعمل 15 ليدز لغايه دلوقتي، وبالتالي تحصلي على الماكسيمم انفورميشن بوسيبل. العيانين بعد الاكسرسايز تيست بننيمهم على طول. الدكتور يحيى سعد كان برضه بيقول
بنقعدهم الاول.
بيقعدهم الاول. ليه بننيمهم على طول؟ لانك انت لما بتنيميهم على طول الانكريز فينس ريتيرن بيكمبريس الاندوكارديوم، والكمبريشن بتاع الاندوكارديوم ستينوزس اوريدي اسكيميك وبيكام مور اسكيميك. عمرنا ما شفنا من دول اريزميا بسبب انك انت، هو كان بيدعي ان العيانين بيموتوا صدري من كده. طبعا زي ما انتم شفتوا بعد كده في عشرات السنين ما فيش عيانين بيناموا لانك بتنيمين. العيان اللي بيموت وهو اللي بيموت عباره عن 1.5 مليون بيموت على التريدميل، ما بيموتش لما بينام.
محمود امين خد مني السؤال، الاكس واي زد ليدز دي بنحطهم ازاي؟
الاكس واي زد دي كانت ليها قصه، دي كانت الاسم بتاعنا مشهور بيها لان كانت من رساله نبيل الشريف.
نبيل الشريف
دي يعني الارتوجنال ليدز دي كانت بتتعمل انها بيتعمل صندوق. الصندوق ده هو فيه الالكترودز متوصله، واحد انتروبوستيريور وواحد من الرايت تو ليفت وواحد فوق الدماغ وتحت الرجل، دول الارتوجنال بلينز. لكن طبعا الالكترونيك الكتروكارديوجرامز بيطلعهم من الالكترودز البوزيشن عاديين. يعني ما عدناش بنعمل حكايه الصندوق ده ولا اي حاجه، انما هي كانت كده. هو ده الارتوجنال ليدز.
كمل بقى يا محمد يا ثابت، معلش انا اسفه للتدخل.
لا انت شرفتينا.
هو في سؤال يا دكتور بيسأل عن الاي سي جي اللي حضرتك عرضته بتاع الولف باركنسون وايت. هو بيسأل why the ST elevation in EVR is not the prognostic for coronary spasm or lesion.
AVR is non-specific lead لأنها بتوري cavity pattern، وبالتالي احنا الكافيتي باترن ده هو بيبقى جلوبال لكل الاندوكارديوم، فما تقدرش تقرا منه لانك انت ممكن تلاقي اس تي ديبريشن بسبب الريبولاريزيشن تشينجز اللي موجوده في الاندوكارديوم، لكن rather than اس تي. احنا بيهمنا جدا ان احنا ما نقراش من وان سنجل ليد، ان احنا نقرا من فرايتي اوف ليدز. مفيش coronary artery anatomical coronary artery we supply area that can be depicted by one single lead. وبالتالي عشان كده بقول لك بص في 3 ليدز. نفس الحكايه في النيوكلير، لازم تبص في كذا صوره جنب بعض. لازم تبص في 3 ليدز وتتاكد ان البيز لاين بتاعهم كويس، وتتاكد ان التشينجز في الاس تي سيجمنت كونسيستنت في الثلاثه. اي في ار ما تقدرش تتاكد منهم الحاجات دي. فحكايه ان في سبازم في الرايت كورونري ارتري appears in AVR is not logic. ليه؟ لان الرايت كورونري ارتري supplying essentially الرايت ventricle وsupplying البوستيريور descending left ventricle، واخد بالك؟ لكن الاي في ار بتبص للكافيتي بتاع الليفت ventricle، مالهاش دعوه بالرايت ventricle اطلاقا، رغم ان اسمها اي في ار يعني.
اوكي تمام. هو في سؤال بيسأل حضرتك جاوبت السؤال ده. Why is stress ECG acceptable for right bundle and not and contraindicated in left bundle؟
زي ما قلت ان هو الرايت باندل الاي سي جي از ليفت فنتريكلوجرام. الرايت فنتريكل بيبان لما يبقى هايبرتروفي، لكن او انفاركتد يعني في سبيسيفيك باثولوجي، لكن الليفت فنتريكلوجرام هو ده اللي دومينيتنج الالكتروكارديوجرام. So if you get a left bundle you get marked the repolarization changes, marked abnormality in repolarization in the main chamber which is being imaged so to speak by the electrocardiogram.
في سؤال بيسأل عن downgrading of exercise ECG in the new guidelines. دكتور محمد.
هو احنا داون جريد اكسرسايز. احنا ما حدش يطلع بعد المحاضره دي يقول ان احنا لغينا الاكسرسايز اي سي جي، لكن ورينا عده نقط مهمه. نمره واحد انه ده probability تيست، بتحول من هاي probability الى لو probability، او ما هواش diagnostic of anything. نمره اثنين ان هو بالاضافه الى كده هو ان هو inflated، السنسيتيفيتي بتاعته inflated اكتر من الحقيقه، والسنسيتيفيتي بتاعته deflated اكتر من الحقيقه، فهو needs to be corrected. وطبعا احنا بنستخدم ال 55 65 ولا 66 وال 75، ما بنستخدمش ال 45 وال 80، ومتغاضين عن الفيريفيكيشن اندكس ما فيها مغالطه. فبما انه imperfect تيست، وبما انه الاكسرسايز اي سي جي بالذات does not localize the region of ischemia، فليه حجمه الطبيعي. هو ما اتلغاش وهو بيستخدم في اغلب الناس، لكن هو at the same time لازم تعرف انت تستخدمه في مين. فالكومنست كونترا انديكيشن ليه مش ليفت باندل برانش بلوك ودبليو بي دبليو اس تي ديبريشن ولا بيست بي. الكومنست انك تعمله او انك تستخدمه في اسيمتوماتيك اندفيدوالز. يعني الاي سي جي ده الاكسرسايز اي سي جي مش معمول في سكريننج البوبيوليشن. سكريننج البوبيوليشن زي ما انا وريتكم السلايدز دي مهمه جدا. السكريننج البوبيوليشن هو البولد كوهورت ايكويشن او ان ايكويفالنت، لكن مش مع والاند بوينت بتاعتها مايوكاردال انفاركشن نوت مورتاليتي. لكن هنا في الديزيزد اندفيدوالز بقت قصه ثانيه الاكسرسايز اي سي جي. So exercise ECG should be used in the appropriate patient. مين الابروبريت بيشنت؟ واحد عنده symptoms، واحد عنده readable electrocardiogram، واحد كان اكسرسايز، وواحد من الانترميديت بري تيست probability. هم دول اللي احنا بندور عليهم. حكايه بقى ان العيان يجي نحطه على التريدميل ونشوف التريدميل هيورينا ايه، ده مش appropriate thing. واحد عنده symptoms، واحد intermediate grade of probability، ما عندوش manifestations من الليفت باندل الحاجات اللي هي كونترا انديكيشن اللي احنا قلناها ده هو، ويقدر يكسرسايز والاي سي جي بتاعه ريدبل. هم دول اللي احنا بندور عليهم. دول مش قليلين، دول اللارج ماجوريتي. هل دول نحمل لهم احسن اكسرسايز ايمجنج لانه بيتر سنسيتيفيتي وبيتر انكريمنتال فاليو؟ نو، لان زي ما انتم شفتوا ان وريتكم انا كذا سلايد موري انه الفرق ما هواش كبير وان الفرق مكلف، فما فيش ما يدعو.
اوكي تمام. في سؤال بيسأل عن الرول اوف سب ماكسيمال ستريس اي سي جي ان diagnosis of ischemic heart disease.
احنا وي بلان ان احنا نخلي العيان اكسرسايز ل 85% of maximum predicted heart rate for his age and sex. below that اذا كان positive فهو positive. إذا above the إذا كان negative then the test is cannot be interpreted, is indeterminate. يعني إذا كان العيان هاي exercise. طيب إمتى exercise العيانين ل 75 و70 وحاجات زي كده؟ هو ده في special situation. Peripheral vascular disease is an example. إحنا بين peripheral vascular disease ما يهمناش الماكسيمم هارت ريت ولا الماكسيمم دبل برودكت، انما يهمنا ان العيان يوري كلوديكيشن ولا لا. فبنحط العيان على التريدميل نمشيه على سرعه ثابته ونزود الاليفيشن بس، وما يهمناش هو بيوصل لقد ايه. طب وبالنسبه للهارت، زمان قبل ما يبقى عندنا الجايد لاينز اللي حددت مين في الاكيوت كوروناري سندروم يروح للقسطره ومين اللي ما يروحش للقسطره، وفي الاغلبيه ان اغلبهم بيروحوا للقسطره ان لم يكن كلهم، كنا العيانين اللي عندهم unstable angina after they get stabilized we exercise them 3 مرات. المره الاولانيه قبل ما يخرج عشان نحط شوف ايه التريتمنت اللي ياخد، فكنا بنكسرسايز them to 70% of the maximum heart rate. This is sub maximum ما توصلش ل 80. الهدف ان انا ان مش عارف انه عنده اسكيميا ولا لا، لان انا عارف انه unstable angina. الهدف ان انا اعرف هو قد ايه يمشي على التريدميل، قد ايه significant اسكيميا، هنديله تريبل انتي اسكيميك ميجرز ولا 1 ولا 2 الى اخره. وبعد كده بعد ما بيخرج كنا بنكسرسايز العيان تاني عشان نشوف الريسبونس بتاعته ميديكال تريتمنت. وبعدين بعد شهرين 3 العيان اوريدي رجع لشغله بنكسرسايز هيم ثالث، بس المره دي بقى ماكسيمم اكسرسايز تيست. سو ده كان الرول للسب ماكسيمم اكسرسايز تيست. سو افتكر دي البوينتس اللي هو الواحد المفروض يعرفها عن السب ماكسيمم اكسرسايز تيست.
اوكي تمام. كان في سؤال دكتوره وفاء كانت بعدها بتسال الاكسرسايز اي سي جي we use all chest leads or can we use V1 and V5 only؟
ما انت جاوبت
يا دكتور محمد جاوبه يا ابني.
اوكي تمام. خلاص مفيش اسئله تاني.
طيب انا عاوز اقول حاجه مهمه، وهو ازاي يتكتب الريبورت بتاع الاكسرسايز تيست. يتكتب الريبورت بتاع الاكسرسايز تيست، يعني الريبورت بتاع الايكو بيتكتب بيرفكت، لكن مش ضروري المعلومات اللي فيه تكون صح، لكن مكتوب من الناحيه الشكليه بيرفكت. المضمون ده متروك لله، لكن هنا المضمون والشكل ما هوش كافي. يعني العيان اكسرسايز على انهي بروتوكول؟ موديفايد بروس بروتوكول ولا بروس بروتوكول؟ انا عارف ان نوتن والرامب والحاجات الثانيه دي هي ما حدش بقى بيستخدمها، دي نمره واحد. وانت فور كام منت؟ الدبل برودكت بتاعه كام؟ او هو وصل لماكسيمم هارت ريت قد ايه؟ دي تكون كام برسنت من الماكسيمم بريدكتد هارت ريت فور هيز ايج اند سكس؟ البلاد بريشر ريسبونس بتاعه قد ايه؟ هل جاله مانيفستيشن اوف تشيست بين ولا لا؟ هل جاله مانيفستيشنز اوف هايبوبرفيوجن ولا لا؟ يعني في وبعدين الديوك ريسك سكور، لان الديوك ريسك سكور هو اللي بيخليني اقول العيان ده هو لو ريسك ولا انترميديت ريسك ولا هاي ريسك. طبعا في اذر ريسك سكورز زي كليفلاند ريسك سكور وكذا، في كذا ريسك سكور، لكن الموست فاليديتد طالما العيان تحت ايج 75 سنه وجري على ستاندرد بروس بروتوكول، عشان كده احنا بنشجع ان يجري على ستاندرد بروس بروتوكول، يبقى العيان ده هو اللي كتب له ديوك ريسك سكور and full stop. There is no suggestion this patient is an indicated for coronary angiography. مش شغلتك. اوكي؟ So next time will be 7:30 next Friday nuclear.
شكرا دكتور محمد، ربنا يكرمك.
شرفتي.